Most of us have had an episode of chickenpox at some point in our lifetime. Today we're going to talk about chickenpox. Hello, welcome to Dr. Ignacio's Medical Tutorials. I'm Dr. Ignacio School, so let's learn about chickenpox. So, it is actually a self-limiting childhood exanthem in most healthy children, and it can be a serious disease in neonates, immunocompromised patients, pregnant women, and even healthy children and adults. So talking about the Etiopathogenesis, it is caused by varicella zoster virus, which is a DNA virus of the herpes family. So we can see the varicella zoster virus and a person affected from chickenpox. So how does it transmit? It is transmitted by airborne spread through respiratory secretion, like sneezing, coughing, etc. Or it can also be caused by direct contact with the skin lesions. So talking about the etiopathogenesis, the portal of entry is the respiratory tract. The incubation period is 10 to 21 days, and the period of infectivity is 24 to 48 hours or 1 to 2 days before the rash appears and until the vesicles are crusted. Note, the crusted scabs are not infectious, so once the vesicles have crusted and healed, the patient is no longer infectious. The secondary attack rates are 80%, so in susceptible individual, if they come in contact with the secretions, then they can get chickenpox. The chance is 80%. Varicella zoster virus establishes lifelong latent infection in the sensory ganglia. Reactivation of varicella zoster virus can lead to dermatomal rash of herpes zoster. So what are the clinical features? Chickenpox is rarely subclinical, but only a few lesions may be present in some healthy children. The peak age of disease is 5 to 10 years, that is the school-going age. So what are the prodromal symptoms? There are fever, malaise, a feeling of weakness, headache, and anorexia. The rash usually appears 24 to 48 hours after the prodromal symptoms. So talking about the rash, 24 to 48 hours after the prodromal symptoms, rash appears is intensely pruritic, very itchy, erythematous macules, so red spots, which are first seen in the trunk. The red spots rapidly spread to the face and extremities, while it evolves into papules, now which can be palpated, clear fluid-like vesicles, also called dewdrop on rose petal, and clouded vesicles, and then crusted vesicles. Crops of lesion appear, and there is simultaneous presence of skin lesions in varying degree of evolution. This is actually an important clinical feature of chickenpox, and the median number of lesions can vary from around 300 or can be from 10 to 1500. So these are the rash of chickenpox in different stages: the papule, the blister or the vesicle with a classical dewdrop on rose petal appearance, and the ulcer, which is most probably due to excoriation. So this is also the early and the late stages. This is another picture of a child with chickenpox. So disappearance of rash. The systemic symptoms persist for 2 to 4 days after the appearance of rash. The rash lasts 3 to 7 days and leaves behind hypopigmented or hyperpigmented macules that persist for days to weeks. Scarring is unusual. So these are the resolved chickenpox rashes. So what are the complications? In the skin, the complication can be secondary bacterial infection, which is quite common, and necrotizing fasciitis, which is quite rare. The neurological complications can be meningitis, encephalitis, acute cerebral ataxia, transverse myelitis, Landry-Guillain-Barré syndrome, and optic neuritis. Other complications include purpura fulminans, CNS vasculitis, immune thrombocytopenic purpura, Ray's syndrome, progressive varicella syndrome, congenital varicella syndrome when the pregnant mother is infected, and herpes zoster. So we'll be talking quite a bit of detail on this progressive varicella syndrome. It is a very dreaded complication and it occurs in immunocompromised individuals, neonates and pregnant women. It is characterized by the development of lesions, hemorrhagic lesions, coagulopathy and visceral organ involvement, including hepatitis, pneumonia and encephalitis. This progressive varicella syndrome is very dangerous with a very high mortality rate. So diagnosis is mostly clinical, but Jank smear of the lesion shows multinucleated cells. This is the Jank smear showing multinucleated giant cells. An IgM antibody to varicella can also be found. So what are the treatment? It can be symptomatic treatment is usually done. Antipyretics are given. Aspirin is contraindicated because of risks of Ray's syndrome, which is very fatal. And ibuprofen is also contraindicated because of high risks of necrotizing fasciitis. Antipruritic agents like antihistamines are given. The child should not attend school until no new lesions appear and all the lesions have crusted. Administration of oral acyclovir, which is an antiviral drug, 20 mg per kg dose 4 times a day for 5 days. Within 24 to 48 hours of onset of rash can be done. Adult dose is 800 mg for chickenpox. And in some cases like completely sedated varicella or the progressive varicella syndrome and the symptoms occurring in high-risk groups like neonates and immunocompromised, we can actually give intravenous acyclovir. So prevention can be done by post-exposure prophylaxis by the use of varicella zoster immunoglobulin or the use of live attenuated varicella. So the vaccines, it is a live attenuated vaccine and their commercial name is Varilrix and Ocavax, and the schedule are for people children less than 13 years or single dose subcutaneous is enough, but after 13 years 2 doses are recommended and the interval between the 2 doses should be 4 to 8 weeks. Thank you. This has been Ignatius Cole. Please subscribe. Thank you.